Welcome to the Mayo Clinic Cardiovascular Continuing Medical Education Podcast. Join us each week to discuss the most pressing topics in cardiology and gain valuable insights that can be directly applied to your practice.
Hello, I'm Dr. Tom Allison from Mayo Clinic Rochester. I'm a member of the Division of Preventive Cardiology, and I have here today with me Dr. Steve Kopecky, who's also in Mayo Rochester in preventive cardiology. And we're going to discuss recent developments in the field of lipid management. Now, Steve, you know, a few years ago, this was all pretty much statin, but in the last few years, we've had a number of new drugs emerge. Are we nearing the end of the statin era?
You know, Tom, that's a great question. And you know, to me, lipid management is getting more like hypertension. You know, the new drugs came along for hypertension, but we didn't give up the old diuretics and things like that. And I think that the statin era is not going to be over.
So statin first.
Yeah, statin first. If they can tolerate it, manage it. If they get them to goal, great. If not, you know, add other things to it.
Now, what about the statin intolerant patient? Where do you go with that patient? Do you have a first choice of drug, or give us a little insight into how you proceed? Because I know you run the statin intolerance clinic here.
Yeah, statin intolerance, and you know, there's been recent studies, old studies, new studies, that kind of show the similar thing, and that is that if someone is statin intolerant, they can't get to goal with the LDL because of a statin side effects, then what do you do? And you know, what can you help a patient with? I think it's important for patients to understand three things. Studies have shown they have to know that the statins are beneficial for them, and that cholesterol actually does cause some problems. And then they need to know the statins are safe, and we need to tell them that. If a statin if a patient's intolerant to statin, what we do is stop it for a month. If their symptoms don't go away, we say, okay, it wasn't the statin, restart it, or if it does go away, start a different one, because all the statins are different in efficacy and side effects. And then we'll get them to what they can get to in terms of lowering their LDL with daily statin, and if they can't take a daily statin, then try less than daily statin, and maybe for about 3 months, and then check their lipid levels, then maybe add in generic ezetimibe, because it really gives you, I call it a statin-sparing agent, because it gives you much greater reduction in LDL than you would get if you doubled the statin dose. And it's very well tolerated, too. Then we can start to add other things to it, but they're new, they're expensive, you know. But some patients, we need to go the full route, especially if they have aggressive coronary artery disease.
Can you give me a ballpark figure? What percentage of these statin-intolerant patients do you end up recommending PCSK9 inhibitor? Yeah,
that's a good question. It's a small percentage unless they have FH or aggressive disease. So maybe 20% we have to go that route.
Okay. So let's talk about a couple of non-LDL issues. Now, you know, triglyceride has waxed and waned. I mean, there was one point where we were very interested in. Then we sort of completely dropped interest when we found out about some bad interactions between fibrates and statins. We had some negative trials with fibrates, but now we're back on track. So this Reduce It trial and some of the subgroup analyses here are showing that reducing triglycerides with that particular agent seems to be very potent, but maybe other agents don't work. I'm confused. Can you straighten me out on triglycerides?
Yeah, that's another great question. The Reduce It, it's interesting. It's icosapent ethyl, and its active metabolite is EPA. And the regular good old fish oil that we gave. It shows benefit. It is helpful in terms of lowering triglycerides. The study was done, Reduce It, that you mentioned. Initially, you had to have triglycerides of 175 or higher. During the study, they actually changed it to 200 or higher. But then when the indication comes out, it seems to be 150 milligrams of per deciliter of triglycerides. That's on top of having a well-controlled LDL of under 70. But they still got about 25% reduction in events, which is interesting to people because the other studies that use regular old generic type fish oil, EPA and DHA, did not get those benefits. So people have said, was it the placebo in the
mineral oil?
Mineral oil, right? Did that cause problems? Why is it better? Why is it they've shown benefit?
I haven't been taking too much mineral oil, so I think I'm okay.
That's right. Good plan. So it's not really clear why it showed benefit, but it did seem to show benefit, and some of the sub-studies have shown some benefit in terms of regression and such. So we're stuck here with giving a drug that when your triglycerides are over 150 and LDL is well controlled, this is something that may benefit them. And but it's $300 a month. You can get copays and cards and coupons and things like that, but it's still an expensive drug, and it's still one more drug to take.
So I'm certain that you probably start with exercise program, diet, weight loss recommendations for high triglycerides before you go to the drug.
Yeah, that's a very good point. And because all these drugs, everything was really, starting with statins, was indicated in addition to lifestyle, as you mentioned, a different diet, et cetera. You can do a great job lowering triglycerides with some physical activity, which will lower triglycerides, cutting out processed carbohydrates, which will lower triglycerides, and then the fish oil.
So if I'm taking some over-the-counter form of fish oil, would you tell me to stop that, or do you think that might play a role if I can demonstrate that it's lowering my triglycerides?
Yeah, I think for primary prevention, if you're not high risk, I would say stay on the fish oil that you're on, the generic stuff. I think where the REDUCE-IT study showed us that these patients with known ASCVD or with very high risk of primary prevention, that's who it seemed to help.
Yeah. Now I'm going to ask you maybe an even trickier question, and that is, what do we do about LPA? Do we have drugs for LPA, and what's your practice in terms of LPA? Yeah,
and LPA, it's present in 20% of the population, elevated levels. It is the triple whammy of lipidology, meaning that it actually is an LDL cholesterol-carrying type drug, so it causes plaque formation. It is pro-inflammatory, so it causes the plaque to then to rupture, and it's procoagulant because then it will cause the clot to form. So it really is an increased risk factor, and the recent guidelines said over about 55 milligrams per deciliter is increased risk. We don't have any drugs approved by the FDA for LPA reduction. We do have the PCSK9 inhibitors that lower it by about 25%, but they're not approved for lowering it. So it's other drugs are coming along. They're being studied. Maybe in 2 or 3 years they'll be out. We're keeping a list of patients with high LPAs that we may be able to start them on if it shows benefit. But for now, we really don't have anything indicated, but it's a side effect, a good side effect of the PCSK9 inhibitors.
Okay, so that would help you. We go back to that statin intolerant patient. If LPA is involved, then we might favor PCSK9 more strongly for that patient.
Yeah, that's in theory true. If I say that to the third-party payers, they say we don't care about that. It's not indicated for that. And so don't try to say it to get it approved.
Okay. And sort of last question here. Let's stick with a question about PCSK9. I'm not aware of any data suggesting that PCSK9 is also going to help you with triglycerides. Is that correct?
No, I think that is true. We just don't see much benefit from it.
As Hamlet said, about my brain. Here I thought I was done with the questions, Steve, and I just remembered, I forgot to ask you specifically about bempedoic acid.
Yeah, interesting drug.
Can you give us some insight on that?
Yes, it's approved now, especially aimed at the statin intolerance market. It's an ACL inhibitor, ATP citrate lyase inhibitor. It's a prodrug. It's activated in the liver. It actually is upstream from where the statins work, and it will lower LDL cholesterol about 18-20%.
Kind of ezetimibe range.
Yeah, in ezetimibe range on top of a statin. There are some issues with it. There are some side effects. You raise your uric acid level. You have to check uric acid. It can be troublesome in patients with gout. There seems to be an instance of increased tendon rupture occurs in the first couple of 3 months, so you got to be careful with that. And then you can't give it with simvastatin more than 20 or pravastatin more than 40 milligrams because of an interaction. But it seems to have a place. It's not inexpensive. Again, you get coupons and such. It seems to have a place, but we reserve it after the generic drugs are used.
Okay, thanks. So, Steve, we've covered a lot of stuff, okay? And maybe there are still some unanswered questions that perhaps in another year or two might be solved with new drugs and new studies. But let's summarize where we are now. So am I correct in saying that statin is still our number one choice in almost all patients for risk reduction through lipid management?
Yes.
Now, for statin intolerant patients or those who aren't getting to goal, it sounds like ezetimibe is our first go-to.
Correct.
Okay, we might add bempedoic acid, but probably our next drug is going to be the PCSK9 inhibitor.
Yes.
Okay, triglycerides, we're going to try to deal with that through behavioral changes, but we may prescribe icosapent ethyl if we're not getting good control of triglycerides.
Yeah, especially the patients with
in high-risk patients.
Yeah, high risk or known disease.
And finally, LPA is an important risk marker, particularly in patients with early ASCVD or family history, familial hyperlipidemia. Maybe they don't get a good statin response, or we're seeing disease progression despite good doses of statin and otherwise good risk factor control. But we really don't yet have good targeted therapy for it.
Correct.
Okay. Well, thank you all for your attendance, for listening in to our discussion, and especially thank Steve for your expertise and not just the information, but really for the wisdom that you provide.
Thank you, Tom. Great to be with you as always.
Thank you for joining us today. Feel free to share your thoughts and suggestions about the podcast by emailing cvselfstudy@mayo.edu. Be sure to subscribe to the Mayo Clinic Cardiovascular CME podcast on your favorite platform and tune in each week to explore today's most pressing cardiology topics with your colleagues at Mayo Clinic.